This is your surgery faculty, Dr. Pritesh Singh. Let's start the session. First, you can see here, 43 years old female presents to OPD due to changes in the breast and a lump. You can see the changes in the breast and there is a lump. Biopsy was done which confirms the breast cancer. So, patient is having breast cancer. Identify the stage of breast cancer. Guys, can you tell me the answer? In this case, you can notice that there is pudgy orange. Apart from pudgy orange, you are going to notice that what? There is erythema. So, apart from pudgy orange, there is erythema also. Erythema, right? It is T4D. It is T4D, and yes, because here you can see the skin involvement, more than 33% of breast skin is involved. So, this is T4D. Why? Because what is this malignancy, guys? This is inflammatory breast cancer. The malignancy is inflammatory breast cancer. Let's quickly revise the staging. You know what is T1? T1 is the size of tumor up to 2 centimeter. What is T2? You know that it is more than 2 to 5 centimeter. And what is T3? You know T3 is more than 5 centimeter. After that, T4 is further divided into T4A, T4B, T4C, T4D. You know what is T4A? याद करने का आसान तरीका, A means अंदर. So whatever is under breast, मतलब there is involvement of chest wall. So in this case, whenever there is involvement of chest wall, you know that chest wall means, what is the meaning of chest wall? Chest wall means ribs plus intercostal muscles plus serratus anterior. So this is T4A, and you know what is T4B? B means bahar. Bahar ka structure means there is involvement of breast skin, and whenever there is involvement of breast skin. So what are the changes, guys? You know there is ulceration, there is edema including pudgy orange, there is satellite nodules. So ulceration, edema including pudgy orange and satellite nodules. Clear? So all these are included in T4B, and you know that what is T4C? T4C is both T4A plus T4B, and what is T4D? All of you know the answer. It is inflammatory breast cancer, and I am repeating the definition of inflammatory breast cancer. How much breast skin should be involved? More than 33% of breast skin should be involved by inflammatory changes. So here the correct answer is D. So correct answer is option D. Okay. Now see the next question. See, it's very important, and multiple times this question was asked, guys. Tell me what is the correct answer. One by one, let's discuss. First, pudgy orange, and you know pudgy orange, it is because of lymphatic permeation by tumor cell. There is dimpling, there is puckering. Both dimpling and puckering is because of involvement of ligament of Cooper, and cancer in cuirass, it is because of involvement of breast skin and chest wall. So cancer in cuirass because of involvement of breast skin and chest wall. So guys, what is the correct answer? Almost everybody is correct. You can see here it's 1B, 2 and 3, that is A and 4C. Clear? So it is 1B, 2A, 3A, 4C. So correct answer is option B. It's 1B, 2A, 3A, 4C. Clear? This is very important. Almost every year you are going to get a question related to pudgy orange. So what is pudgy orange? There is involvement of lymphatics. So permeation of lymphatics by tumor cells. Because of that, what will happen? There is obstruction of lymphatics, and you know it leads to cutaneous edema. That is pudgy orange. Dimpling and puckering, you guys know it is because of involvement of ligament of Cooper. Let's quickly revise, guys. You can see here this is dimpling. Can you see here? This is dimpling. What do you mean by dimpling? You have seen dimples. So you have seen dimples. Dimples means skin depression. So here there is skin depression. Clear? What is dimpling? That is skin depression. What is puckering? Have you used tissue paper? So it's the crumpled appearance. Crumpled appearance, that is, here you can see the wrinkling in the breast skin, that is puckering, and here you can see multiple nodules are there, that is cancer in cuirass. So multiple nodules because of involvement of breast skin and chest wall, cancer in cuirass. Clear? Now guys, see the next question. First tell me what is the name of this flap. Can you see this here? You can see the flap. Can you tell me this flap is based on which artery? You know guys, what is the name of this flap? You know this is tram flap. What's the name? This is tram flap. Can you tell me the full form? Transverse rectus abdominis muscle flap, and you know that it is based on this artery. Which artery? Inferior epigastric artery, inferior epigastric vein. And here it's a free flap, so it is devascularized from donor site. It is revascularized at recipient bed. So can you see here? I am going to revascularize it with internal mammary vessels. You can see inferior epigastric vessels are anastomosed to internal mammary vessels. Name of flap, tram, and it is based on inferior epigastric vessels. Guys, inferior epigastric vessels, what is the correct answer here? The given flap, you know, it is tram flap. So the name of given flap, guys, it is tram flap. Tram, it's tram flap, and you know that this tram flap, it is based on inferior epigastric vessels. Can anybody tell me LD flap, latissimus dorsi flap, it is based on which vessels? LD flap. Sir, why it is not DIP flap? Can you tell me what is the full form of DIP? This is deep inferior epigastric artery perforator flap. Deep inferior epigastric artery perforator flap. In DIP flap, we are not taking the muscle. Muscle is spared. Here we are taking only skin and fat. And can you see this image? If you see this image carefully, guys, see, I am cutting the muscle. So if you are taking the muscle, it is tram flap. If you are sparing the muscle, that is DIP flap. Two questions are asked frequently. What is the most commonly used flap for breast reconstruction? Tram. And which flap is best flap? That is DIP. Why? Because if you are taking tram flap, there is weakness because you have incised or you have cut the muscle. In DIP flap, muscle is spared, that's why there is no hernia. So that's why DIP flap, best flap, most commonly used flap, that is tram flap. Another question, tell me, this thoracodorsal vessels, which flap is based on thoracodorsal vessels? Yes, thoracodorsal vessels. Which flap is based on these vessels? You know, it is LD flap. And there is PMMC flap, pectoralis major myocutaneous flap, which is based on interpectoral branches of thoracoacromial vessels. So here, guys, what's the correct answer? Correct answer is inferior epigastric vessels. Okay, inferior epigastric vessels. Correct answer is option B. Next, you can see which of the following is not a contraindication of breast conservation surgery. I am waiting for your reply. Let me see who is going to mark this question correctly. Which of the following is not a contraindication? Not. Guys, let me tell you, scleroderma, yes, it is a relative contraindication. History of therapeutic radiation exposure, this is absolute contraindication. Absolute contraindication. Multiple cancers in one quadrant, it's not a contraindication. And persistently positive margin, again it's an absolute contraindication. So which of the following is not a contraindication? Actually, this kind of question was asked in last INI-CET. You have to remember, multiple cancers in one quadrant. So can anybody tell me what are the absolute contraindications? Pregnancy, multiple tumors in different quadrant, diffuse microcalcification, persistently positive margins, inflammatory breast cancer. These are absolute contraindications. And what is relative contraindication? Collagen, vascular disease, clear? Large tumor in small breast and large pendulous breast. So these are absolute contraindication, clear? So guys, here what is the correct answer? The correct answer is option C. Multiple tumors in one quadrant is not a contraindication. Multiple tumors in two or more than two quadrants, that's absolute contraindication. So correct answer is option C. Now see this, first see this image. You can see this patient. This patient is having exophthalmos. Can you see? Ophthalmopathy. Now read the question. Read the question, guys, and tell me what's the correct answer. 25 years old male patient complains of palpitations, sweating and restlessness. Okay. He has complaint of sweaty palms. Clinical findings are depicted in the image showing bilateral exophthalmos. You can see what is the diagnostic test done. So you know the patient is having signs and symptoms of hyperthyroidism. Classically, patient is having exophthalmos. You can see the patient is having diffuse toxic goiter. What's the name, guys? You know, Graves. Name of this condition, it is Graves disease. So what's the name? The patient is having Graves disease, and in Graves, you know, it's autoimmune disorder. What is the name of autoantibody? It's LATs. It's LATs. So guys, it's LATs. You know, when kids are not studying, especially in UP and Bihar, they get the LATs. It's long acting stimulation. LATs, if you get in childhood, there is long acting stimulation. So this is how you have to remember LATs, long acting thyroid stimulation. And this LATs is against which receptor? TSH receptor. So it is against TSH receptor. So it is not anti-thyroglobulin antibody. It is not anti-thyroid peroxidase antibody, because you know that it is in Hashimoto's. This is in Hashimoto's anti-thyroid peroxidase, that is anti-TPO. Thyroid receptor antibody. So what is the correct answer here? Option C, elevated ultra sensitive thyrotropin levels. No, this is also incorrect. So what is the correct answer? Option C, thyroid receptor antibody. Clear? What is the correct answer, guys? It is C, option C. Next question. Read it and tell me what's the correct answer here. Guys, tell me what's the correct answer. 30 years old female with diffuse thyroid swelling. On investigation, TSH levels were elevated. Post-operative histopathological examination reports showed intense lymphocytic infiltration and, most important, what? Hurdle cells. Which of the following is correct about this condition? Patient is having hypothyroidism. There is lymphocytic infiltration, presence of hurdle cells. You know what's the diagnosis? The patient is having Hashimoto's. So this patient is having Hashimoto's thyroiditis. Hashimoto's. So Hashimoto's thyroiditis, and you know that this is an autoimmune disorder. What is the autoantibody? Anti-TPO. Here there is hurdle cell, Eskenazi cell. It leads to permanent hypothyroidism. You know, it leads to permanent. It leads to permanent hypothyroidism. Permanent hypothyroidism. Clear? That's why we are supposed to give lifelong levothyroxine. You know that it's a risk factor for malignancy. The name is Hashimoto's thyroiditis, also known as struma lymphomatosa. Can you see this? The name is struma lymphomatosa. Struma lymphomatosa means conversion of thyroid tissue into lymphoid tissue. So here, what's the problem? Can anybody tell me it is going to increase the risk of which malignancy? Can you see it's written? Name is struma lymphomatosa. Guys, tell me. Lymphoma. Apart from lymphoma, this is also going to increase the risk of papillary carcinoma. So lymphoma and papillary carcinoma. So let's discuss the options one by one. One by one, guys. See the first option, increases the risk of papillary carcinoma. Correct. Eskenazi cells, hurdle cells are seen. Correct. Levothyroxine should be given lifelong. Correct, because patient is having permanent hypothyroidism. So can you tell me what is the correct answer? Correct answer is option D. Now see the next question. 23 years old male presents with midline swelling in the neck. Swelling moves with deglutition and on, most important, protrusion of tongue. What is the likely diagnosis? You know, all thyroid swellings move with deglutition, but only one swelling moves up on protrusion of tongue. Which one? You can see here. This is the tongue. You can see this. This is the tongue. This is the foramen cecum, and this is thyroglossal tract. And you can see here, this is hyoid bone. Where is the cyst? Infrahyoid or subhyoid, since it is attached to the tongue, and whenever a person is going to protrude the tongue, swelling moves up. So what is the diagnosis, guys? Everybody is marking correct answer, thyroglossal cyst. And you know what is the most common location? It is infrahyoid. Infrahyoid. Another question, it is going to increase the risk of one malignancy. You know which malignancy? Papillary carcinoma. Increased risk of papillary carcinoma, and all of you know the treatment of choice, cyst trunk. So what's the name, guys? It is cyst trunk operation, cyst trunk. And what you do in cyst trunk operation? There is en bloc excision of cyst along with central part of hyoid bone. So this is cyst trunk operation. This is thyroglossal cyst, though it's congenital. Age of presentation is 15 to 30 years. It's congenital, but age of presentation, it's congenital, but age of presentation is 15 to 30 years. Clear? 15 to 30 years. So what is the correct answer? Option B. Now see the next question. 45 years old man with midline swelling presented with odynophagia. Can you see this? Odynophagia and dyspnea. Swelling showed cells with variation in size and morphology. Amyloid deposits was seen. Most important, amyloid. Patient brother complains of headache, diaphoresis, palpitations. Patient's father expired because of cerebrovascular accidents. What's the most likely diagnosis? First, can anybody tell me why his brother was having PhD? Palpitations, headache, diaphoresis. This PhD is the triad of this triad. And you know why this tumor is associated with pheochromocytoma? Because this is medullary thyroid cancer, MTC. Medullary thyroid cancer, and you know that this medullary thyroid cancer, it is associated with MEN2A2B. And here in MEN2A2B, there is pheochromocytoma. That's why his father expired because of cerebrovascular accident. Clear? Second characteristic feature, the patients who are having medullary carcinoma thyroid, there is raised calcitonin. These patients have raised calcitonin. There is presence of amyloid stroma or deposit. Amyloid stroma or deposit, and these patients are having history of diarrhea. History of diarrhea. Here the patient, here the tumor is TSH independent, that's why this tumor is not going to take radioactive iodine. So, radioactive iodine ablation is useless. Here what kind of surgery is done? We perform total thyroidectomy plus removal of inlays plus routine central lymph node dissection, and if the size of tumor is more than 1 centimeter, we perform ipsilateral MRND, and if any lymph node is positive, you go for bilateral MRND. So, guys, what's the correct answer? Correct answer, it is medullary carcinoma. Okay. See, we are expecting similar question in exam, and you know medullary carcinoma arises from parafollicular C cells. Parafollicular C cells which are derived from ultimobranchial bodies, and it is going to secrete what? Calcitonin. Easy. Next question. This was similar question was asked in one of the latest exam, guys. See first, in the skull bone, can you see there are osteolytic secondaries? So, you can notice in skull bone osteolytic secondaries, in which case you are going to find osteolytic secondaries. Two malignancies which are having pulsatile secondaries. One is RCC, second is follicular carcinoma thyroid. These malignancies are having pulsatile, you know, pulsatile secondaries. What do you mean by pulsatile secondaries? This is osteolytic and hypervascular. This is osteolytic and hypervascular, pulsatile secondaries, osteolytic and hypervascular. So, one question for all of you, what is the most common route of spread in follicular carcinoma thyroid? Hematogenous. And what is the most common site of metastasis? Bones. Can anybody tell me which bone? Waiting for your replies. Let me see who is the genius over here. Which bone? Most common site of metastasis, guys, which bone? Very good. It's vertebra. And in vertebra, which one? Vertebra, which one? Thoracic vertebra. Let me tell you, it goes to flat bones. So, what? It is vertebra followed by ribs, followed by pelvis, followed by skull, VRPS. Vertebra, ribs, pelvis, skull. And what kind of secondaries will be seen? You can see osteolytic. So, guys, here based on the provided image, osteolytic secondaries, type of thyroid malignancy responsible, you know what? Follicular. So, what is the correct answer here? It is follicular carcinoma. I am repeating the questions. FNAC cannot differentiate follicular adenoma from follicular carcinoma. That is why diagnosis made by biopsy. Since there is no lymph node involvement, we are not going for lymph node removal, and all of you know what is the treatment of choice? It is TT. TT means total thyroidectomy. So, what is the treatment of choice? It is total thyroidectomy. Clear? Now, see the next question, guys. Next. Similar question was asked in one of the latest exam, very easy. See the question. Malignant neck swelling was surgically removed from the patient, shown in the image below. What is the symptom likely to be developed within 2 to 3 days? First, tell me the name of surgery. The whole thyroid is being removed. Can you see this? The whole thyroid is being removed. So, name of surgery TT. It is total thyroidectomy. Whenever there is total thyroidectomy, if you are going to ligate inferior thyroid artery away from thyroid, in that case there might be vascular infarction of parathyroid gland, vascular infarction, and because of this vascular infarction of parathyroid gland, there is parathyroid insufficiency. Question, on which day? Guys, on which day? 2nd to 5th day. And since there is parathyroid insufficiency, what's the problem? Can you see? Patient is going to develop signs and symptoms of hypocalcemia. That's carpopedal spasm, tetany. On which day? 2nd to 5th day. So, here it's not the deviation of angle of mouth, hoarseness of voice, it's because of injury of recurrent laryngeal nerve. It is going to manifest immediately after surgery. It's not the migratory superficial thrombophlebitis. Correct answer, carpopedal spasm. Okay? Carpopedal spasm. I am repeating the question again. On which day of surgery hypocalcemia manifestations are seen? 2nd to 5th day of surgery. Got it? So, correct answer is option D. Now, see the next one. Next, very easy and very important. See, 42 years old woman has a non-specific right upper quadrant pain. Excised tumor gross section is shown below. What's the diagnosis? First, she is having pain in right upper quadrant and the tumor is, tumor is arising from the liver. Tell me the liver tumor which is having this kind of scar. Can you tell me guys what is this scar? This is this kind of scar. What? Central stellate scar. Can you tell me which tumor is having central stellate scar? FNH. So, two important questions related to FNH. First starts from F. It is more common in females. And which females associated with OCPUs? F, females, OCPUs, there is central stellate scar. You can see this scar on CT, and if you perform angiography, I am asking this question. There is central feeding arteriole with multiple peripheral branches. Anybody tell me what is the name of this characteristic appearance? Guys, there is central stellate scar. Tell me what is this characteristic appearance? There is central stellate scar. And what is this characteristic appearance? Yes, it is spoke wheel or cartwheel appearance. So, guys, this is spoke wheel. What's the name? This is spoke wheel or cartwheel appearance. Right? So, this is spoke wheel or cartwheel appearance. So, spoke wheel or cartwheel appearance. Cartwheel. So, this is spoke wheel or cartwheel appearance. What is the correct answer here? The correct answer is, correct answer is option A, focal nodular hyperplasia. Clear? So, correct answer is option A. Clear? Now, see the next question. Easiest question, it was asked multiple times in exam. Tell me guys, what is this? See this? This is typical appearance. Can you see this? Here floating membrane or undulating membrane, and it looks like water lily or water snake sign because it is floating on the surface. So, water lily or water snake. So, according to Gharbi classification, what is type A? In type 1, in Gharbi's classification type 1, there is simple fluid collection. Simple fluid collection. Type 2, there is floating membrane or undulating membrane. Undulating membrane. This is also known as water lily or water snake sign. So, this is water lily or water snake. So, this is water lily or water snake sign. What is type 3? Type 3 is multiseptated or multiloculated. That is known as honeycombing. So, this is multiseptated. What is type 4? Here there is complex heterogeneous mass. And what is type 5? Calcified cyst. So, floating membrane, undulating membrane, water lily, water snake, all these are seen in type 2. Remember, this is Gharbi's classification. WHO classification is different. That starts from CE1, CE2. That's different. You have to remember that also. This is Gharbi's. So, this is Gharbi's classification. Yes, that is CE1, CE2. That is WHO classification. This is Gharbi's. Now, see this. Which of the following statement is correct? Guys, I am telling you, almost every year you are going to get MELD score, PELD score, CTP score. MELD, it's model for end stage liver disease. PELD, pediatric end stage liver disease. CTP, child Turcot Pugh score. Now, it's very easy to remember. Yes, very easy. What's the mnemonic? For MELD score, all of you know the mnemonic is CBI. It is CBI. So, guys, what is CBI? You can see here, creatinine, bilirubin, INR. It is CBI. What is the mnemonic for PELD score? It is NABIA, nutrition, age, bilirubin, INR, albumin. Nutrition, age, bilirubin, INR, albumin. And what is CTP score? Yes, how to remember? Guys, the components are, mnemonic is BAPE. It is BAPE. So, components are BAPE. So, what is that? Bilirubin, albumin, ascites, prothrombin time, encephalopathy. So, bilirubin, albumin, ascites, PT that is INR, encephalopathy. So, BAPE. CBI, here the mnemonic is NABIA, and the third is BAPE. So, what is the correct answer? Correct answer is option D, all of the above. Read this question, guys. 40 years old female presented with jaundice and pruritus. Anti-mitochondrial antibody was positive. Clear? But anti-nuclear antibody was negative. Biopsy shows portal inflammation and ductal proliferation, lymphocytic infiltrate. What is the most probable diagnosis? The most important clue given. That's autoantibody. Autoantibody. So guys, you know this is autoimmune disorder where there is anti-mitochondrial autoantibody. And what's the diagnosis? You know, primary biliary cirrhosis. So I'm going to discuss important questions. This is autoimmune disorder. There is anti-mitochondrial autoantibody. It is more common in females. These females are obese. Because of this, there is intrahepatic destruction of intrahepatic bile duct. And whenever there is destruction of intrahepatic bile duct, so you know that treatment of choice will be liver transplantation, because you cannot repair intrahepatic bile duct. These characteristic pathological changes are seen on biopsy. So investigation of choice for diagnosis, you know, it is biopsy. Since there is destruction of intrahepatic bile duct, these patients are typically having pruritus and fatigue. Most characteristic symptom pruritus and fatigue. Patients are also having jaundice. Typically, pruritus precedes jaundice. So here, most important symptoms are patient is having itching, pruritus and fatigue. Pruritus is most bothersome in evening. Patients are having jaundice, and here pruritus precedes jaundice. These are the questions. So guys, correct answer is D. Here you can see the female. If you see primary sclerosing cholangitis, it is more common in males. Here etiology is not known. Choledochal cyst is also seen in females, but here autoantibody is not positive. So what is the correct answer, guys? Correct answer is option D. First guys, see this. During laparoscopy cholecystectomy, this is the anatomy. Can you see? Guys, can you make out the anatomy? You can see here. Yes. So this is Callott's triangle. Okay. Now see this, it's very easy to understand. Imagine this is the liver, right? You can see this. Here, this is the bile duct. You can see here, this is common hepatic duct. This is cystic duct. And here you can notice this is cystic artery. So this triangle is known as Callott's, and this bigger triangle is known as hepatocystic triangle. Okay, so let's see the question first. During lap cholecystectomy, the surgeon carefully identifies the boundaries of hepatocystic triangle to avoid injury of important structures. Which of the following is not a boundary of hepatocystic triangle? So you can see the medial boundary, it is common hepatic duct, lateral boundary cystic duct, and superior boundary inferior hepatic edge. Inferior hepatic edge. Can you tell me what is the content? Guys, content, the content is cystic artery. So cystic artery is content. So you can see cystic duct laterally, common hepatic duct medially, inferior hepatic edge superiorly. So cystic artery, it's not the boundary, it's the content. Is the content. And sometimes examiners are asking Callott's triangle. So in Callott's triangle, you can see the medially common hepatic duct, laterally cystic duct, superiorly cystic artery, and in Callott's triangle there is a lymph node. This is lymph node of Lund. Cystic lymph node, that is lymph node of Lund. So what is the correct answer? Correct answer is option D, that is cystic artery. Clear? Now see the next question. Following image depicted bile duct injury shows which type of Strasberg classification. So you know that Strasberg classification of bile duct injuries. What happens? See this first. In this image you can notice that there is cystic duct stump leak and there is leak from subvesical duct of Lashka. Whenever there is cystic duct stump leak or leak from subvesical duct of Lashka, this is type A, and you know type A is most common. What is type B? Transaction with occlusion of aberrant right sectoral duct. Type C. Transaction without occlusion of aberrant right sectoral duct. Type D. There is lateral injury of common hepatic duct, and type E is even to E5 Bismuth classification. So guys, here you can see there is cystic duct stump leak, leak from subvesical duct of Lashka. So almost everybody is correct here. It is type A. You know the most common type of Strasberg classification, it is type A. You know classifications which are going to start from 1, 2, 3, 4, 5, usually the most common type is 1. And if classification is going to start from A, B, C, D, E, what is the most common type? The most common type is type A. So this is the most common type of Strasberg classification, type A. Clear? Everybody is correct. Now see the next question. These similar questions were asked previously in multiple exams, INI-CET, NEET, PG, FMG. Read the question. After lap cholecystectomy, patient started developing pain after some days of discharge. On evaluation, 5 into 5 centimeter fluid collection was present under the liver. What should be done next? Let me explain. Sometimes the bile duct injury is diagnosed in post-operative period, and whenever bile duct injury is diagnosed in post-operative period, first what you have to do, first step is control the infection. So how you control the infection, guys, tell me? You have to start antibiotics. Second step is drain the biloma. How you drain? Drain the biloma. How? Ultrasound or CT guided percutaneous aspiration, or we insert the pigtail catheter. Third, complete the cholangiography. How we perform cholangiography? MRCP, and then you find the stricture. After that, you go for definitive intervention. After that we go for definitive intervention, right? Definitive intervention. Clear? So we go for definitive intervention. So here are the steps. Patient came and on ultrasound there is 5 into 5 centimeter collection, and if there is 5 into 5 centimeter collection, you have to drain it. And how will you drain it? See the options. Ultrasound guided pigtail catheter drainage, correct. Reopen the wound and T-tube insertion. No need to reopen the wound. ERCP with stenting. If stricture is not formed, don't go for ERCP. Give antibiotics and send the patient home. No, because collection is there, we have to drain it. So what is the correct answer here? Guys, the correct answer is option A. Here what is the correct answer? Ultrasound guided pigtail catheter drainage. Now see the next question. An elderly male presented with epigastric pain. See, there is epigastric pain, anorexia, weight loss, jaundice for the last 2 years. Elderly male, most probably patient is having malignancy. He had scratch marks all over the body. Means patient is having itching. On examination, gallbladder was palpable. Kurwai's law. In a case of obstructive jaundice, gallbladder is palpable because of periampullary carcinoma. It is smooth, non-tender. So this patient must be having periampullary carcinoma. And what are the malignancies included in periampullary carcinoma? Ampulla, you can see this is the ampulla, this is ampulla. So within 2 centimeter of ampulla, that is periampullary. So malignancies are ampullary carcinoma, carcinoma head of pancreas, distal cholangio and duodenal. It's not because of choledocholitis. When the stone is there, gallbladder is seldom palpable. It's not because of carcinoma gallbladder, because usually in carcinoma gallbladder, jaundice is a late sign. Here the gallbladder is smooth, non-tender. It's not HCC because in HCC gallbladder is not palpable. Correct answer, carcinoma head of pancreas. Easy. This is carcinoma head of pancreas, right? Option B. Next question. Patient is scheduled to undergo Whipple's procedure for the treatment of pancreatic cancer. After removing the affected tissues, surgeon needs to perform anastomosis to reconstruct the digestive tract. In which sequence are the anastomosis typically performed? Okay, let me explain little bit. Very easy to understand. Have a look. See, this is the patient. This is, you can see this. This is stomach. This is duodenum. This is jejunum, right? This is liver. This is gallbladder. This is the bile duct. How much tissue I am going to excise? You can see distal gastrectomy, gallbladder and bile duct, pancreatic head and uncinate process, and here neck little part we have to remove, whole C loop of duodenum and jejunum. So you are left with proximal part of stomach, liver, common hepatic duct, pancreas, and what else? Jejunum, right? You perform the anastomosis. So this is a loop of jejunum. How you perform the anastomosis, guys? The first anastomosis is PJ. After that, second one is HJ, and the third is GJ. Third is GJ. So first is pancreaticojejunostomy, second is hepaticojejunostomy, third is gastrojejunostomy. So you can see pancreaticojejunostomy, hepaticojejunostomy, gastrojejunostomy. So correct answer is option B. It is PJ followed by HJ followed by GJ. Correct answer is option B. Next, guys, it's very easy. This question was asked multiple times. Tell me the correct answer. Tell me the correct answer. You can see here. What is the most probable diagnosis for patient who is diabetic, developed DVT and necrolytic migratory rash? Classically it is seen in glucagonoma. And what is the other name of glucagonoma? Guys, tell me. What is the other name of glucagonoma? It is also known as hyperglycemic cutaneous syndrome, also known as 4D syndrome. Can you tell me 4D? Diabetes mellitus, DVT, dermatitis, depression. DVT, dermatitis, depression, right? And can you tell me out of these 4 which one is the most common symptom? Yes, dermatitis. What is the special name of this dermatitis? Tell me guys, waiting for your reply. It is NEM. What is NEM? That is necrolytic erythema migrans. So this is NEM. Necrolytic erythema migrans. This is classical feature. You will not hear this term again. And you know, glucagonoma, most common site is body and tail. It is body and tail, and that's why what's the treatment? We have to go for distal pancreatectomy. So what is the correct answer guys? Glucagonoma. It is glucagonoma. In insulinoma there is hypoglycemia. In gastrinoma patients are having peptic ulcer. And VIPoma, what is the other name? This is WDHA. WDHA syndrome is watery diarrhea, hypokalemia, achlorhydria. So here what is the correct answer? Correct answer is option C. Correct answer is option C, right? Now see the next one. Next, tell me what is the correct answer guys here? Tell me which of the following are correct? Correct for herniation via foramen of Mouragagni. You know this congenital diaphragmatic hernia. One is Bokdalek hernia which is posterior lateral. Mouragagni is right anteromedial. That is left posterior lateral, Bokdalek, and this is right anteromedial. So see option number 1 here. It occurs posteriorly in the chest, no, anteriorly. Transverse colon is commonest content, that's correct. Defect is between sternal and costal attachment, this is correct. It's a type of congenital diaphragmatic hernia. So all these are correct. This is also known as Larry's hernia. Usually it is asymptomatic. So correct answer is D. Remember where is the defect guys? Here, right anteromedial. Here where is the defect? The defect is right anteromedial. So defect is right anteromedial, and you know Bokdalek, the Bokdalek hernia. In Bokdalek hernia, where is the defect? In Bokdalek, the defect is left posterior lateral. Left posterior lateral. And one question from all of you, can you tell me the content? In Mouragagni hernia or Larry's hernia, the content is transverse colon. Can anybody tell me what's the content in Bokdalek hernia? Most common content. So what is the most common content guys? Most common content. Here the most common content is small intestine. Small intestine. And you know that Bokdalek hernia, it is characterized by atroid RDS, respiratory distress, dextrocardia, scaphoid abdomen. Most common cause of death, pulmonary hypoplasia. What is contraindicated? Bag and mask ventilation is contraindicated. These are important questions. So correct answer is option D.